Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 156 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, JVC, a 63-year-old man presents to the Accident and Emergency Department in the month of July. He has a past medical history significant for type 2 diabetes mellitus, hypertension and end-stage renal disease. He has a chief complaint of increasing shortness of breath over the past 48 hours, coughing, and subjective chills. His last dialysis session was 7 days ago. His chest X-ray shows bilateral pleural effusions. His pertinent vitals include a body temperature of 37.8 degrees Celsius, a respiratory rate of 22 breaths per minute, a heart rate of 109 beats per minute, a blood pressure of 129 systolic and 87 diastolic. He is being admitted to your general medical ward. His hemodialysis graft appears normal. JVC has no history of infections, recent antibiotic use, or inpatient hospitalization. So my question to you is, which of the options listed below would be the most appropriate therapy to initiate for potential pneumonia for JVC? Would it be A. ceftriaxone, or B. linezolid plus cefepime, or C. azithromycin plus ceftriaxone, or would it be D. piperacillin, tazobactam plus vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. azithromycin plus ceftriaxone. This patient may have pneumonia, given his chest radiography and symptoms. He may also have a component of fluid overload, given his missed hemodialysis appointments. Although, technically, this patient may have healthcare-associated pneumonia, abbreviated as HCAP because of his use of hemodialysis, the HCAP classification will likely be eliminated in favor of patient-specific risk factors such as history of infection with MDROs, or recent antibiotic use. Hemodialysis is not strongly associated with MDRO pathogens. The most likely pathogens for his potential pneumonia are similar to CAP, that is Streptococcus pneumoniae, Haemophilus influenza, atypical pathogens, and respiratory viruses. That makes answers D and B incorrect because they include unnecessary coverage for MRSA and Pseudomonas. According to the available studies, additional atypical coverage may confer benefit in decreasing the time to clinical stability, making answer C correct and answer A incorrect. And the next question reads, 1 day after JVC's admission, a multiplex PCR for viruses and atypical pathogens is negative. Repeat chest imaging after emergency dialysis reveals resolved pleural effusions. His chest symptoms have improved, and he is afebrile. His WBC is 10.6 times 10 power 3 cells per millimeter cubed. 2 procalcitonin values were obtained, one on admission and one 12 hours later, with results of 0.32 mcg per liter and 0.36 mcg per liter, respectively. So my question to you is, which of the following would be the most appropriate therapeutic plan for JVC's potential pneumonia? Would it be A. Continue antibiotics for a total of 1 week, or B. Continue antibiotics for a total of 5 days, or C. Continue antibiotics until procalcitonin is less than 0.25 mcg per liter, or would it be D. Discontinue antibiotics? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Discontinue antibiotics. This patient appears to simply have had fluid overload related to missed hemodialysis sessions, given his improved symptoms and chest imaging resolution after emergency dialysis. The procalcitonin value is above the threshold of 0.25 mcg per liter, which suggests a lower respiratory tract infection. However, this patient has end-stage renal disease, and procalcitonin values, which are elevated at baseline in end-stage renal disease, are often above 0.25 mcg per liter in uninfected patients. Therefore, answer D is correct while answers A through C are incorrect given the patient does not likely have pneumonia. Please advance to the next question. And the next question reads, MKP, a 38-year-old healthy female patient, was involved in a motor vehicle collision, sustaining a traumatic brain injury and severe chest injuries requiring endotracheal intubation and mechanical ventilation. On her chest X-ray, a new left lower and middle lobe infiltrate is noted after being in the trauma ICU for 4 days. Her body temperature is 38.8 degrees Celsius, she has a WBC of 15 × 10⁻³ cells per millimeter cubed and has macroscopically purulent sputum. MKP is hemodynamically stable. Accordingly, a BAL of the affected lung field is obtained by the team to assess for VAP. So my question to you is, which of the following is the most likely causative pathogen of MKP's suspected VAP? Is it A. Streptococcus pneumoniae, or B. MDR Pseudomonas aeruginosa, or C. Legionella, or is it D. Acinetobacter species? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Streptococcus pneumoniae. This patient has VAP without apparent updated risk factors for MDROs. That makes answers D and B incorrect. Pathogens associated with early onset HAP and VAP are usually community-acquired organisms, including Streptococcus pneumoniae (MSSA), Haemophilus influenza, and enteric gram-negative bacilli, which makes answer A correct. Although guideline updates recommend that Pseudomonas aeruginosa coverage be considered as empiric therapy for all patients thought to have VAP, lack of MDRO risk factors decreases the likelihood of MDR strains. Atypical bacteria are rarely associated with early onset VAP, which makes answer C incorrect. If MDRO risk factors were present, MRSA and Pseudomonas aeruginosa would also be considered. Please proceed to the next question. And the next question reads, GTR, a 46-year-old male patient presented at your accident and emergency department 6 days ago with witnessed loss of consciousness and subarachnoid hemorrhage. On admission, he was febrile. A urine culture was done, and he received IV levofloxacin for 5 days for a possible urinary tract infection. He has been intubated since admission and, today, has developed thick secretions. His WBC has increased to 16 times 10 power 3 cells per millimeter cubed. GTR now has increased FiO2 requirements from 40% to 60%. He has been febrile almost continuously throughout his admission. Imaging reveals increasing pleural effusions. The rate of methicillin resistance among Staphylococcus aureus in the unit is 35%. So my question to you is, which of the following is the most likely causative pathogen of GTR's suspected VAP? Is it A. Streptococcus pneumoniae, or B. MDR Pseudomonas aeruginosa, or C. Legionella, or is it D. RSV? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. MDR Pseudomonas aeruginosa. The patient described has late-onset VAP considering that he has been hospitalized for more than 5 days with the updated risk factors for MDR Pseudomonas, considering the fact that he has had prior intravenous therapy. In particular, fluoroquinolones are also independent risk factors for MDR Pseudomonas. That makes answer B correct. Atypical bacteria are rarely associated with VAP, which makes answer C incorrect. Respiratory syncytial virus, abbreviated as RSV, is not a common cause of VAP. Although RSV can cause significant pneumonia in some patient populations, e.g., patients with hematologic malignancy or patients of advanced age, this would typically be community-acquired. That makes answer D incorrect. Pathogens associated with early-onset HAP and VAP are more likely community-acquired organisms, including Streptococcus pneumoniae. However, this patient has late-onset VAP and, more importantly, MDR risk factors, making answer A is incorrect. Please progress to the next slide. And the next question reads, which of the empiric antibiotic regimens listed below would be the best for the likely causative pathogen or pathogens of GTR's suspected VAP? Would it be A. amikacin plus cefepime plus linezolid, or B. vancomycin plus amikacin plus doripenem, or C. vancomycin plus levofloxacin plus cefepime, or would it be D. cefepime? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. amikacin plus cefepime plus linezolid. This patient requires coverage for MRSA because he has a risk factor for MRSA VAP and prior intravenous antibiotic use, and because the local prevalence of MRSA is greater than 10% to 20%. That makes answer D incorrect. The patient requires 2 agents active for Pseudomonas, given his MDR risk factor of prior intravenous antibiotic use. Doripenem has an FDA warning against use for treatment of ventilator-associated bacterial pneumonia, and is thus suboptimal. That makes answer B incorrect. Answer A is more appropriate than answer C because levofloxacin is not as reliably active against beta-lactam-resistant gram-negatives relative to aminoglycosides. Please advance to the next question. And the next question reads, GTR has received a week of active therapy, he now has an FiO2 of 40% and a PEEP of 5 cm of water. He remains febrile, and his WBC is now 8.9 times 10 power 3 cells per millimeter cubed. Procalcitonin obtained at the start of antibiotic therapy was 1.6 mcg per liter. Today, his procalcitonin is 0.13 mcg per liter. GTR's respiratory secretions are minimal. Pseudomonas aeruginosa was isolated on a BAL culture obtained when antibiotics were initiated. So my question to you is, what would be the most appropriate duration of antibiotic therapy in GTR's clinical scenario? Would it be A. complete a total of 3 weeks of therapy, or B. complete a total of 2 weeks of therapy, or C. complete a total of 10 days of therapy, or would it be D. discontinue therapy now? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. discontinue therapy now. This patient has clinically improved, given his ventilatory requirements, decrease in WBC, decrease in procalcitonin to less than 0.25 mcg per liter, and decrease in respiratory secretions. Although he remains febrile, this is likely central fever caused by subarachnoid hemorrhage. He probably did not have a urinary tract infection that needed treatment, either, and was present on admission. Given these data, it is safe to discontinue therapy. That makes answer D correct and answers A to C incorrect. Although Pseudomonas aeruginosa was isolated, there is no mortality benefit with longer therapy durations, according to the NBME study or the meta-analysis included in the 2016 ATSIDSA guidelines. Please proceed to the next question. And the next question reads, CTY, a 34-year-old female patient presents to your accident and emergency department from home. Her chief complaint includes flu-like symptoms for the past 3 days with severe fatigue, shortness of breath, and rigors. Her pertinent vitals include a heart rate of 120 beats per minute, a mean arterial pressure, abbreviated as MAP of 70 mm of mercury, a respiratory rate of 24 breaths per minute, a body temperature of 39.3 degrees Celsius, and her SaO2 is 85% on room air. This is in the middle of influenza season, high prevalence of influenza A and B. A nasal swab is sent for rapid diagnostic testing for suspected influenza infection. Shortly thereafter, CTY is intubated for severe respiratory failure and admitted to the medical intensive care unit. Apart from antibiotic therapy for CAP, which of the following would best be considered next in this clinical scenario? Would it be A. give oseltamivir, or B. give amantadine, or C. await rapid diagnostic test results before initiating influenza-specific therapy, or would it be D. none? The patient is outside the time window to effectively treat influenza. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Give oseltamivir. This patient likely has severe influenza amid a local seasonal outbreak. Local infection patterns suggest a prevalence of influenza A and B strains. Empiric influenza-specific therapy against these strains should be initiated in patients with severe influenza before confirmatory test results are known to avoid a delay in appropriate therapy. That makes answer C incorrect. Neuraminidase-based therapy is recommended for modern influenza A and B strains. That makes answer A correct, and answer B incorrect. Even if they are outside 48 hours from symptom onset, patients with severe influenza have benefited from therapy initiated beyond this period, which makes answer D incorrect. Please move on to the next question. And the next question reads, MDG, a 33-year-old female patient, is transferred to your medical intensive care unit with severe respiratory failure and ARDS requiring intubation after 2 days of malaise, fever, and myalgias. The nasal washing sent by your accident and emergency department for rapid diagnostic testing turned positive for influenza A. The local prevalence of subtype 2009 H1N1 is high. So my question to you is, which of the agents listed below would be most appropriate for initial treatment of MDG's severe influenza? Would it be A. oseltamivir, or B. IV peramivir, or C. inhaled zanamivir, or would it be D. amantadine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. oseltamivir. Given the high prevalence of the 2009 H1N1 subtype of influenza A, oseltamivir is the empiric drug of choice. In addition, oseltamivir has high-level activity against other contemporary influenza A and B subtypes. That makes answer A correct. Zanamivir also has high-level activity against these strains. However, inhaled therapy through the mechanical ventilator is not indicated because of insufficient systemic delivery, and intravenous peramivir is indicated only if oseltamivir cannot be administered, e.g., patient cannot receive enteral medications, or has poor absorption. That makes answers C and B incorrect. Amantadine has insufficient activity against most contemporary influenza A and B strains, which makes answer D incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 157.